Hello, everyone. This is Cheryl Manchenton and Audrey Howard presenting for the November Quality Webinar Series session, which is what is the impact of the IPPS FY 2026 final rule updates? How does that impact CDI and quality? Obviously, again, our speakers are myself, Cheryl Manchenton, and Audrey Howard. Our agenda is to look at specifically the ICD-10-CM and PCS coding updates, the coding guide updates, the DRG updates, the Solventum APR DRG updates, and then any highlights of significant changes to the CMS quality programs. So let's get started, and we will kick it off with first the updates to the ICD-10-CM and PCS and coding guidelines, and how do they relate to Audrey? Audrey, I'm going to turn it over to you.
Thank you so much, Cheryl. Good morning, good afternoon, or good evening, everybody. This is Audrey Howard, and I'm going to be going over some kind of setting up what some of the changes were effective October 1st, and then Cheryl will relate to us how it is impacting any of the quality programs. Overall, from the diagnosis perspective, what is showing on this screen is the number of new codes that were created, what was deleted and what was revised, and knowing that we have just shy of 75,000 ICD-10 CM diagnosis codes available to us that became effective October 1st. Now that was overall. Going into our first change of what we want to talk about is not really a new code, but some of we're also going to be addressing some coding instructional notes that may have changed this year that could impact on quality. So this first one that we're talking about here, once again, not a new code, but it is an added instructional note in ICD-10-CM. Under code category B18, which is for chronic viral hepatitis, a use additional code, if applicable, for ascites was added. Use additional code notes imply that the additional code may be sequenced as a secondary diagnosis after the code where the note is located. Therefore, this is a gentle reminder that it is acceptable to add ascites as a secondary diagnosis if it is present with chronic viral hepatitis. And then on the next slide, you'll see the tabular list related to ascites, category R18. As you can see, the current excludes one note does not exclude the coding of ascites with chronic viral hepatitis, but it does exclude it when present in certain other conditions. Now, Cheryl will explain how this new coding instructional note may impact quality.
Thank you, Audrey. You'll notice that for symbol purposes, we're using X's and check marks, and we'll sometimes have a question mark, meaning obviously it's not a net new code, so it's not going to impact Elixhauser. Ascites is not on the Elixhauser list. It is not an HCC, so the addition of that is not giving us a net HCC, and it's not impacting PSIs or risk adjustment for PSIs. However, we do believe that it will impact risk adjustment in general. As a reminder to code an additional code, and I think with ascites and liver disease, sometimes we have to go back to the code book to double check. Am I allowed to capture this, not capture this, and not having advice on this? I think we probably have underreported this. And in some of the risk adjustment methodologies outside of, like I said, Elixhauser, ascites is an impactor, even though it's a symptom code, because it does denote a worse prognosis in terms of liver disease. So I do believe that, again, some of those methodologies that are proprietary, that it is part of their methodologies, and on the CMS condition category list, not certain because they are modifying from condition categories to individual codes. So ascites might be on that list as well. And here's our next topic.
Thank you. A new code was created for type 2 diabetes mellitus in remission, code E11.A. Notice that the code title is type 2 diabetes without complications and remission. Under the new code, coding instructional notes excludes one notes. In other words, if diabetic complications are present, then the appropriate code from category E11 will be assigned for the specific diabetic complication and not the new code for in remission. In addition, if there are no diabetic complications, but the patient is not in remission, then code E11.9 is assigned. Notice that if the new code for diabetes and remission is sequenced as a secondary diagnosis, it will not be considered a CC or MCC. And finally, if it is sequenced as the principal diagnosis, it is added to MSDRG 637 through 639 and MDC 10. However, it would be extremely rare that this code would be sequenced as the principal diagnosis in the inpatient setting. As we go on to the next slide, you'll see that a new official coding guideline was created explaining the use of code E11.A. One, the code is assigned based on the provider documentation that the type 2 diabetes is in remission. And then if the documentation is not clear regarding if the diabetes has achieved remission, then the provider should be queried for clarification. The guideline made a point of stating resolved is not synonymous with remission. And then Cheryl, go into a little bit more of the clinical background on diabetes before we talk about the quality.
Sure, thank you. So when we talk about what does that mean to be in remission, there is established criteria for that, sustaining normal blood glucose levels for 3 months or more. And there is, clinical evidence that this can occur in a type 2 patient, certainly not a type 1, but in type 2, we can achieve remission through weight loss interventions as a great example. And when you think about the monitoring that would be required for that sort of patient to ensure that they're staying in remission, right, we would need an associated diagnosis that supports the checking of the glucose and the hemoglobin A1C. So, that is why really I believe this code was created, for the ability to track the number of patients in remission and also to have justification for the screening that is required. And again, it is only focusing on uncomplicated diabetes where there has not been any damage to any organs or structures. How does this impact quality? It's a big question mark. And by that, with Alex Hauser, I don't believe it'll be on the Alex Hauser list. We know that we do have diabetes with or without complications as one of our risk adjusters. I don't believe that they will add this code to the list, but I've been proven wrong before. I don't believe, again, that it'll be an HCC, because when you think about resource consumption, how much resource consumption does it take to basically do annual screening, if you will, and ensure that it stays in remission? Like I said, I think time will tell, but at this point, I don't, it has not been added to the HCC list. I certainly don't think it'll impact PSIs for the same reason. Will it be used in risk adjustment? I just don't really know. Like I said, I can argue both sides of the coin, that it does put them at a higher risk, for complications or issues because they have had diabetes in the past. But I don't honestly believe that it will be utilized in risk adjustment. Next topic.
The next topic is a new code G31.87, which was created for primary progressive apraxia of speech, which may be abbreviated as PPAOS. This diagnosis, given when apraxia of speech is insidious, progressive, and the first or only clinical symptom associated with a neurodegenerative disease. It is not considered a CC or MCC when reported as a secondary diagnosis, and is classified to MSDRGs 56 or 57 and MDC1 when sequenced as a principal diagnosis. So Cheryl, how does this new code, or how may it impact quality?
And I think that's the big question, is the may, right? Because To me, it's a precursor of more significant neurologic diseases. In other words, it might be a symptom. I know it's not a symptom code, but it could be the first sign of a much more comprehensive condition. So will Elixhauser, HRQ add that to their Elixhauser list? I really don't know. Again, there is a whole category for other neurologic disorders in which similar types of conditions would occur, but just a little too early to tell if they're going to add that. And we won't see that most likely this fall with the fall changes that should come out in December or January, but maybe subsequent years. I think it depends on how much it is actually coded and reported. Again, at this point, it is not on the HCC list. It is not going to impact PSIs, and whether or not it'll affect risk adjustment, again, I think time will tell. And on to our next topic.
Next one is thyroid eye disease, or TED, or TED, also known as Graves' orbitopathy. It is a sight-threatening autoimmune disease occurring most commonly in hyperthyroid patients and less frequently in hypothyroid and euthyroid patients. The new codes are included under subcategory H05.83 with a specific code identifying laterality. None of the new codes are classified as CCs or MCCs. And notice that there is a code also note under subcategory H0583 for autoimmune thyroiditis or thyrotoxicosis with diffuse goiter. The code also note does not imply sequencing, and sequencing will depend on the circumstances of admission. So Cheryl, how may these new codes impact quality?
This is a yes. I do believe it will be added to the Elixhauser conditions because we do have a category for thyroid disorders. So I would assume that this code will be added to that. Again, the question is, it's not a current HCC. Will it be added in terms of, it is obviously impacting care and treatment and monitoring ongoing. It's not a condition that magically goes away, if you will. Again, I don't believe that it will be a PSI. And again, it could or could not be used in risk adjustment. I think, in other words, in places in which thyroid hypo or hyperthyroidism is utilized in risk adjustment, I think that this new code will then be lumped into that. But if it's not in a model in which those are utilized, I don't think it will be used in risk adjustment. So it's a cautious question mark at this point. And here's our next topic.
Next topic is related to category I-51. The main change is that the excludes one notes related to hypertension were moved from the category level at I-51 and added to the individual code level under codes I-51.5 and I-51.7. The reason for this is because of the different guidance depending on the condition when present with hypertension. To further clarify, the guideline was updated, as we will see on the next slide. Under the guideline for hypertension with heart disease, which is category I-11, the first paragraph is providing guidance on how to code hypertension with heart conditions classified to category I-50, heart failure, code I-51.4, myocarditis, and codes I-51.89 and I-51.9. The guideline states to assign a code from category I-11 along with the additional code for the heart condition. However, if the hypertension is with heart conditions specified as myocardial degeneration, I-51.5, or cardiomegaly, I-51.7, then only assign a code from category I-11 for the hypertensive heart disease. No additional code is assigned to identify this specific heart condition when it's present with one of those two conditions. So Cheryl, how may this impact on quality?
So I think this is really a nothing burger. And I mean that meaning the two codes that we can't code anymore are something that we typically don't assign. In other words, sometimes we see a bunch of big changes to the guidelines and it seems like a major important thing we should be paying attention to. In this case, I'm calling it a nothing burger, meaning Okay, I cannot now code these. I probably wouldn't have coded these because these patients typically have something else that's reportable, which is why I just barely put a question mark on the risk adjustment. But sometimes we like to point out not everything is as exciting in the code book updates or the coding guidelines as other things. And I think this falls into that category. Our next topic, Audrey.
I'll change to coding instructional notes is under subcategory J84.1, which is other interstitial pulmonary diseases with fibrosis. The revision involved changing the excludes one note to a code also note. Therefore, both the interstitial pulmonary diseases with fibrosis and the pulmonary fibrosis due to inhalation of chemicals, gases, fumes, or vapors can be assigned when both are present and reportable. Cheryl, talk to me about quality on this one.
So I do think that this is impactful and meaningful. And by that, um, the ability to capture multiple chronic lung conditions or acute and chronic lung conditions, depending on what type of that is, I think is going to impact risk adjustment and our Alex Housers because we do have different lung conditions, if you will, in different Alex Houser categories. And again, the more insidious or more rare lung disorders are certainly big risk adjusters. So I do think that there will be a positive impact in both of these categories. And our next topic.
Next topic is a whole bunch of new codes, and those new codes were originally created for the specific location of non-pressure chronic ulcer of skin. The new codes were specifically requested to be able to classify xylazine-associated wounds. Xylazine is an FDA-approved medication for use in veterinary medicine. It is not approved for use in humans due to unsafe hypotension and central nervous system depression. Therefore, xylazine is an illicit drug on the streets. According to studies, there is a higher prevalence of skin wounds among people who injected xylazine-containing drugs compared to people who injected drugs without xylazine. Xylazine-associated wounds are often recognized by the presence of necrotic tissue, so eschar and slough, and wound diameters greater than 10 centimeters. Xylazine-associated wounds increase a person's risk of bacteremia, endocarditis, sepsis, limb amputation, and death. So this slide is showing 40 of the newly created codes under category L98. Once again, each new code is specifying the location. And then there are also 6 characters that are available with each of the new codes that identifies the depth of the ulcer. Notice that some of the deeper ulcers, that's getting more specific, are considered CCs. But wait, there's more of these new codes, and that you'll see on the next slide that this is showing an additional 72 codes that are specified sites and depth of ulcer as well. It's necessary to note that just because these codes were created to identify xylazine-associated ulcers, if a patient is diagnosed with a non-pressure chronic ulcer of the skin of any of these sites, the code will be assigned. All of the new codes are now available to be able to pick up the anatomical site involved. Excuse me. And as we go on to the next slide, if it is associated with xylazine, then one of these new codes on this slide from subcategory T6584 will be sequenced first. Notice the coding instructional note under the subcategory states to use additional code for all associated manifestations such as, and that's including your cellulitis and the non-pressure chronic ulcers. The use additional code note means that the code listed is listed as a secondary diagnosis. So Cheryl, talk to me about the quality on this for all of these brand new codes.
So I think it is interesting because we had junk codes, if you will, for lack of a better word. We had very unspecified or other specified location for a lot of these ulcers, meaning we've had non-pressure ulcer codes for years. They added additional very specific location because these were the more common sites, if you will, of those xylazine associated ulcers. But having further specificity, I do think will impact risk adjustment because some sites are more significant than others. And again, anytime that we're able to provide more specificity, it's used better in data research and outcomes and can be factored into risk adjustment. And kind of a reminder, as Audrey was saying, these new codes were created. The title is the same as any of the other skin ulcers that are not, pressure in nature. In other words, it's not a new category or descriptor for skin ulcers. It's just location specificity added with the pre-existing depth that we already had before. So, like I said, I think better code specificity leads to better research and better measurement of outcomes and their impact of these ulcers on things such as HCCs. Next topic.
Next new code is for cannabis hyperemesis syndrome, code R11.16, which is a gastrointestinal condition associated with chronic cannabis use. It is characterized as with severe nausea, vomiting, and abdominal pain that occurs in a cyclical pattern of 3 or more times a year. Sometimes, symptoms usually start suddenly within 24 hours after the last use of cannabis and generally lasts less than a week. Cheryl, talk to me about quality.
Again, I think it's a big question mark. I am very glad that there is a specified code because it is, instead of just having to go to a junk code for just nausea and vomiting, which is a symptom code, having a specific one that shows an cause and effect relationship could mean that it is utilized in risk adjustment. Right now, again, predecessor codes related to it were not. LX Housers or HCCs are used in HRQ. But I do think over time, in the next few years, the more of this very specific disorder that we're reporting, I think it will be utilized in risk adjustment. Again, I'm leaving it a question mark, but I do think it will be impactful because, again, the amount of resources used to treat this, it's a very difficult condition to treat. It's not just straightforward treatment and care, right? Because some of those patients do need to be on cannabis for medical reasons. And so trying to balance the amount of cannabis and the use of other meds that could possibly have side effects, I do think it will be resource impacting. So I think, again, over the next few years, it might even be added to the HCC list. I think it's a stay tuned, but it's a very welcome code. Next topic.
Now we're going to move on into the social determinants of health. There were some inclusion terms and instructional notes that were added to various codes to provide guidance on what is included under that specific code. So, for example, the inclusion term workplace stress was added to code Z56.6, and lives in a homeless encampment was added to Z59.02. And then on the next slide, there were a few new social determinant codes, social determinants of health codes that were created. Specifically, code Z59.861 was created for financial insecurity, difficulty in paying for utilities, and code Z59.868 was added for other specified financial insecurity, which also includes bankruptcy. Cheryl, talk to me about the social determinants of health and how that may impact on quality.
So as many may know, the adoption, expansion of the SDOH codes were part of the Gravity Project, which started back in 2019 as a way to better characterize, those factors influencing our patients' health. So it's been a planned series, if you will, of rollout of codes. More so the individual factors, meaning unique to one particular individual. There is a plan, as far as I've read and understand, that they'll start talking about larger community factors, such as lack of groceries nearby or things like that. But at this point, like I said, this is a planned project between the Gravity Project and the Coordination and Maintenance Committee to expand these codes. As many of us will know, when they started expanding the homelessness codes, right? Some of those certainly became CCs or again gave us more specificity. And I do think that there is a difference between unspecified homeless versus sheltered homelessness, as an example. And in the same sort of vein, financial insecurity. I can remember when the code was released, and now that we have further specificity, bankruptcy versus can't pay utilities, those are two different types of patients with two different types of issues that could impact their health. I can remember a patient I had who went home, basically AMA. He needed a cabbage and he said, my house is about to be foreclosed on. I need to leave. He was filing bankruptcy and other things. And, that was a huge influencer, obviously, to his hospitalization. Other patients not being able to keep their utilities on could again impact their health for sure. So I think over time, the more of these that do get reported in our top 25 codes, right? Because CMS and HCUP only involve the first listed 25 diagnosis codes. The more of these that we can get sequenced, captured and sequenced in the top 25, I think the more that they can be used for risk adjustment. And here's our next topic.
The next topic is related to some changes in the official coding guidelines. So we wanted to add those revisions that were related to BMI. We know that in order to add, to be able to add a BMI code, there first needs to be a corresponding diagnosis documented by the provider. So what was added, because the example was always, such as obesity. Well, now they've added the corresponding diagnosis could be, for example, anorexia. So letting you know that it's not just a high BMI that we're needing the corresponding diagnosis, but also a low BMI that you'll need the corresponding diagnosis. So just anything that would support why the BMI value itself is of clinical significance, you need to have that corresponding diagnosis provided by the provider, documented by the physician. Also, additional information was added to the guideline related to fluctuating BMI values. It added when the documentation reflects fluctuating BMI values during the current encounter for an associated reportable condition, assign a code for the most severe value. So Cheryl, talk to us about how this impacts on quality reporting.
Certainly. Well, first of all, we did have a coding clinic about the fluctuating BMI. So them codifying it into the official coding guidelines, I think is very important and significant. So I appreciate that. This is one that I can actually give you very clear guidance that it does impact risk adjustment. I do have a client that uses the premier risk adjustment models and quality measurement. And there is a difference clinically between a patient who has obesity with a BMI of 32 compared to one who has a BMI of 38, right? Those patients are not the same. And so the ability to code that highest BMI during the stay is actually a variable. It's not the obesity that is used in the risk adjustment, but the actual BMI. So for those that follow Premier, like I said, I can only speak to Premier because my client shared that information with me. It is proprietary to those members. But for those that follow Premier, this is huge. Again, I don't know if Vizient or others are using these BMIs in their risk adjustment, similar to what Premier is. But I do think it's important that we do get the appropriate BMI reported. And again, as a reminder, to be capturing those low BMIs in the same vein. It wasn't just for malnutrition, if you will. So I appreciate that expansion. Like I said, I can definitively say this is a risk adjuster. And Audrey, our next topic.
Next topic, and for actually the next 6 slides, we're going to be going into some of the major changes that were updated in the HIV and AIDS official coding guidelines. Now, the whole thing was revamped actually, but to be honest, what it seems like is that they were just rewording it to adjust to assist with the appropriate code assignment and to hopefully make things clearer. Nothing was really changed. I think it just was modified for wording for the clarity of everything. Excuse, I am so sorry. For example, this first guideline for HIV disease was included in the prior guidelines, but it was moved to the front and center and rephrased to state, if the term AIDS or HIV disease is documented, or if the patient is treated for any HIV-related illness, or is described as having any condition or conditions resulting from the patient's HIV positive status, code B20 should be assigned. The next major update for patients with HIV disease is admitted with an unrelated condition states that B20 is still assigned, but as a secondary diagnosis along with the codes for the other documented conditions. And then going to the next slide, we see that the guideline on asymptomatic HIV was updated to state when HIV positive, HIV test positive, or similar terminology is documented, and there is no documentation of symptoms or HIV-related illness, code Z21 should be assigned. Next, code R75 is assigned for patients with documentations of inconclusive HIV serology. Now on to the next one. So the guideline G, once again, was updated for clarity. The guideline for a patient previously diagnosed with an HIV-related illness was updated as presented on this screen. Essentially, code B20 is assigned for patients with documentation of a prior diagnosis of an HIV-related illness. It states, once an HIV-related illness has developed, code B20 should always be assigned on every subsequent admission or encounter. Please note, though, that the code assignment is based on documentation from each individual encounter. Notice that the guideline includes documentation of a prior diagnosis. Therefore, that documentation needs to be included in the current encounter to be able to support the code assignment of B20. So every record still needs to stand on its own based on the documentation, but once B20 is assigned, it should always be assigned on every subsequent encounter. That is a good query opportunity if the present record, your current encounter, is not supporting that information. Going on to the next slide, guideline H then is related to pregnancy, as shown here. Code O987 is sequenced first, followed by code B20 for pregnant patients with documented symptomatic HIV disease or an HIV-related illness. Remember, always codes from chapter 15, which are your pregnancy-related codes, always take sequencing priority. So the pregnancy code first, followed by the B20 in this instance. Moving on to the next slide, the guideline for encounters of HIV testing is updated as shown here. A lot of green and red on this one, but once again, the codes assigned have not changed, just the rewording of the guideline for clarity. And then on the guideline J, finally, this guideline for HIV disease or HIV positive status managed by antiretroviral medication was updated. I appreciate this revision for this guideline. The guideline always stated if a patient with documented HIV disease, HIV-related illness, or AIDS is currently managed on antiretroviral medications, assign code B20. But then the following was added to this guideline. If a patient with documented HIV positive status is currently managed on antiretroviral medication, assign code Z21, asymptomatic human immunodeficiency virus, or the HIV infection status, in the absence of any additional documentation of HIV disease, HIV-related illness, or AIDS. So in other words, if the patient is documented as HIV positive status only and they're on the antiretroviral medication, then you'll still assign the Z21. The fact that they're on the antiretroviral medication does not impact on the code assignment in that case of what the documented diagnosis is. So those were a lot of updates related to the HIV and AIDS, and I appreciate that they put all of this in here for clarity. So Cheryl, talk to us on how this may impact on quality. And
Absolutely. And as Audrey said, these were published in coding clinics, right? So they're now just codifying them in the official guidelines. And I think this has huge impacts on quality because it's giving us clear directive on when we should be assigning the B20 versus the Z21. And we already know that there's an Elixhauser category for HIV. So I think there's a huge impact there as well, as we will have more cases, I do believe, appropriately coded when they have had some historical disease or diagnosis related to their HIV. So I think we'll see definite impact, or conversely, patients who should not have the B20 assigned will not be included in this. So I do think that there's both positive and negative impact. And really, I should have had a check mark on the patient safety indicator, the HRQ, because they do risk adjust based on some Elixhauser categories. So I do think it will have impact there. And certainly, again, HIV as a disease, I should say, the actual conversion over to HIV disease is a huge risk adjuster. It is certainly has a huge impact on patients' severity, mortality, morbidity, all of those things. So again, I think long term, the accuracy of our data and the reporting of these HIV conditions, or just being HIV positive, as we noted, will have an impact on risk adjustment and quality. And so we're going to transition.
We are transitioning now into the procedure codes. And so as you can see here, just the summary overall, effective October 1st, 156 new procedure codes were created with 27 deleted procedure codes. And we're going to hit on some of those major ones that could impact on quality reporting for this year. So as we go on, you'll see, first of all, the first procedure of discussion is the creation of a code which describes the insertion of endovascular anchors in initial endovascular aortic aneurysm repair, or the EVAR, or in a revision of the prior endovascular aortic aneurysm repair. The new code added device, intraluminal device, endovascular anchors to body part descending thoracic aorta to supplement table 02U. On the next slide, you'll see another new code was created under body part abdominal aorta, once again to show the insertion of endovascular anchors in an EVAR. Cheryl, before you talk about quality, do you mind talking about some of the clinical aspects of this insertion of the endovascular anchors?
Happy to do so. And obviously, to me, this is interesting and fascinating. Many times we know that I'm back from the days when we did Dacron graft replacements of the aorta to where now we have stents. So it's a lot less invasive to patients to have a stent insertion. Unfortunately, they don't come without complication, meaning often the stent doesn't stay where it's supposed to, and or they do get what's called an endo leak, right? That leakage around that stent. They don't get a good seal between the vessel wall and that stent. So these anchors are meant to literally hold them in place so that they don't migrate, and secondly, to reduce the incidence of the endo leak. So I think it is fascinating technology that we can specifically say, I'm going to put you here and I expect you to stay here, and I don't want anything to come in between that stent and that vessel wall. So how does this impact quality? Now you see a bunch of red X's here, right? Because it's a procedure, and we know typically procedures aren't used. This is also a supplemental procedure, meaning it's not the first listed procedure code. It's telling us more, but I do think that for our research scientists, I think this is important, that we'll be able to measure long-term outcomes and look at the differences in patients in which we did or did not use these anchors, or as newer technology is developed down the road. So it's not a direct impact on our quality reflection right now, but I do think again, having better data for research outcomes long-term is going to have a benefit to us and the quality of actual care we deliver. Let's talk about our next new code.
This is a fun code to discuss if that's even possible. But the next procedure we are going to discuss is the cricothyrotomy. 6 new codes were created by creating a new table 0C1, bypass of mouth and throat. Notice that the MSDRG for these codes are classified to either MDC3, which is ear, nose, and throat, or MDC4, respiratory. The new codes are not considered the same as a tracheostomy. So that's setting up the new codes. But now I'm going to let Cheryl talk about the clinical aspect of this before discussing the quality.
Certainly. So to me, I've been doing this 17 and a half years, and it's shocking to me that we did not have a code for a crike. And again, I'm going to just use the abbreviation crike because that's how we would describe it. The fact that we were assigning it to a code for an insertion of the trachea, when it doesn't go in the trachea, it literally goes through the cricothyroid membrane into the larynx, has been just amazing to me that we didn't have a unique code, right? So I just want to talk about why they needed to create it, because we should have had a unique procedure code for it because of its location. Again, you can see kind of an image here that shows how that would occur. So it's up higher in the neck, if you will, than the tracheostomy. Also, to make it easier for some of us who may not understand where the cricothyroid cartilage or membrane is, they updated the PCS code book where we talk about this body part, goes to this PCS value. So, moving it away from the trachea, which again was clinically wrong, to the larynx for those that don't have the slide deck handy and aren't certain, where do I go with this? But as Audrey said, how does this impact quality? This is actually a big one. It's not going to impact our Elixhausers, and it's not an HCC because, again, that's a procedure. But the way that HRQ assigns exclusions, first of all, is based on the MDC. So it's moving it out of the pre-MDC in DRG 003 and 4 into either, again, MDC3 or MDC4. So, for example, in MDC4, where, we have our respiratory conditions, it's going to stay in there instead of ending up in unrelated. Now, cost-wise, there are some people saying, dang nabbit, it's a lower weighted DRG. Yep. Well, it's also an easier procedure, and sometimes it's just an emergent procedure. It's meant to be a temporary thing. It's not a permanent airway. It is a life-saving intervention for those that ever saw the MASH episode with the pen. That was a crike, right? But, typically if the patient's going to need a long-term airway, they will then convert over to a tracheostomy. But for the patients who need it transiently for a respiratory obstruction, if you will, or, severe allergic reaction with the closing of the throat, this is going to move out of the pre-MDC. Okay, so it will impact in terms of exclusions and risk adjustment, because HRQ risk adjusts by the MDCs of our patients as well. It doesn't just provide exclusions, but it risks adjusts. Now, how will this impact other types of risk adjustments? I really can't say. I think it will. I just think those models are going to be reevaluated to determine, is this a risk adjusting procedure, right? Is this used because of this procedure? Will it be used in risk adjustment? For example, in some models, including Solventum, administration of TPN or administration of enteric feedings is used sometimes in the overall SOI and ROM. So whether or not that this unique code will be used in risk adjustment, I think time will tell. Like I said, I would be shocked if it doesn't, but I can't obviously prove that at this point. And on to our next procedure.
The next procedure that we're discussing is the temporary intraoperative embolic protection procedure codes. These codes were originally added to the new technology section. Now they are moved to the extracorporeal or systemic assistance and performance section in table 5A0, with function cerebral embolic filtration added with 4 different qualifiers. These codes describe the utilization of temporary intraoperative embolic protection devices to capture and remove debris that may dislodge during an interventional procedure with the intent to reduce the incidence of adverse effect. So this is where the new codes were added, but on the next slide, you'll see that as I stated, they were originally created and put into the new technology section. So they've deleted those 4 codes from the new technology table X2A and then added to what I showed you on the previous slide. So it's just that they're no longer new technology, but there is high volume of it and enough for it to be put into the regular, quote unquote, regular chapters of PCS. So Cheryl, talk to us about how this may impact on quality reporting.
And this is a supplemental procedure, meaning it's not driving our DRG assignment. So similar to our previous section where we had supplemental codes for the anchors, I don't know that this is going to have a huge impact directly on quality and risk adjustment. Do I think it'll have an impact on the actual quality of care and how the researchers can have more specific data to determine how effective this is at preventing complications, and should this be a routine standard of care? There's certain things we do nowadays that we wouldn't even question that we always do as a standard of care, and will this shift that over in the actual care of the quality we delivered? Probably, I think so. Our next topic.
Next one is one new procedure code was created to identify the use of protective insulation device on the donor kidney graft during a renal transplantation. This code is used in addition to the kidney transplant code. Cheryl, talk to me about quality for this new procedure code.
Again, it's a supplemental code, right? It's not the first listed code. It's interesting because when you think of renal transplants, it is the transplant that we are very fortunate in that it takes, we can preserve that organ longer, that you can have such a thing as an elective renal transplant. It's the only one that we can preserve on ice, if you will, and they have other protective fluids that they have used to prolong it outside of the body and still be able to be transplanted. So this is actually a very cool, pardon the pun, but a really interesting new code. I don't think it's going to have a direct impact again on our quality, but I think the data science is looking at the outcomes of those renal transplants and how well that they do function and maybe decrease complications post-transplant, I think will be interesting in years to come. Here's our next new code.
Finally, these are going to be the last of the new procedure codes that we'll be discussing. And this includes specific codes that were created for negative pressure wound therapy. It's 8 new codes, and the 8 codes will depend, or each specific code will depend on the site of where they are doing the negative pressure wound therapy. So they are located in table F08. The negative pressure wound therapy aims to treat complex wounds which are non-healing or at risk of non-healing, such as the diabetic foot ulcers or skin grafts. So Cheryl, talk to me about quality on these new procedure codes.
Similar to the other 2 new procedures, I think they're interesting. I think that they will be used by data scientists long term to look at what are the best modalities for wound healing of complex wounds. I think, like I said, having very specific codes for this unique type of wound treatment will actually aid in delivering quality of care and studying the best ways to deliver that. But again, probably not a direct impact on our code assignment in terms of code quality reflections, etc. As Audrey said, we're going to transition over to the new or the MSDRG updates that may impact quality.
And there were not as many changes as in overall new MSDRGs or deleted or revised this year, but there was some shifting that was going on. So we'll discuss some of the highlights of that. I'm always talking about numbers and everything. It is always interesting to note that now with the changes that you see here, which was not really a big net gain because we actually deleted one, but for fiscal year 2026, we now have a total of 772 MSDRGs. So we're getting up there. The first change that really want to go through is not a new MSDRG or deleted, but there was a lot of shifting around. And so we're going to be discussing specifically MSDRGs 20 through 22. And what's showing on here is a summary that 61 procedure codes were added to the intracranial vascular procedures logic list in MSDRGs 20 through 22. These procedures that are listed here that include the dilation, extirpation from certain areas were excluded from the intracranial vascular procedures logic list when they were comparing to other logic lists in 23 through 27. So they're wanting to make it more clinically coherent. So this one is just adding 61 procedure codes to that logic list in 20 through 22. On the next slide, you'll see that 66 diagnosis codes were added to the hemorrhage principal diagnosis logic list, once again in MSDRGs 20 through 22. So once again, it's just basically making it more clinically coherent, any of the replication errors and updating it to make sure that what it needs to be added to the logic list are included in those. So Cheryl, talk to me about quality when it comes to these procedures and the diagnosis codes that were added.
Again, sometimes I'm going to use the word huge. This is one of those. Because when you put the patients in the right clinical DRG, in terms of severity of illness and risk of mortality, they're not the same patients. DRGs are set not just for payment, but for also APR DRG, or again, MSDRG risk adjustment. So putting them in the place they belong, right, is very important. This will impact PSIs because remember that they risk adjust not only on the MDC of the patient, but on the individual MSDRGs of those patients. And these patients in this set of DRGs are some of our sickest neurologic surgery patients who have a much higher risk of complications than some of the more simple, and I'm using my air quotes here, craniotomy procedures. So it is a big impact, not just on the AHRQ world in terms of risk adjustment, but also, again, in any of the other models, including Solventum's APR-DRG methodologies. And here's our next set of changes.
Now we're still in MDC1, the neuro system, in those procedures, but now we're really discussing MSDRG 23. And these 4 procedure codes were added to the anti-neoplastic implant logic list. And in fact, because these 4 procedure codes were added, they actually revised the logic list to say anti-neoplastic implant. Changed it to that and kind of revised the title of MSDRG 23. So adding these 4 procedure codes to that logic list. And then on the next slide, still within MSDRG 23, but also 24, added these procedure code combinations to MSDRGs 23 and 24 under the major device implant logic list that would describe the implantation of your deep brain stimulation system depending on what type of generator that was being used and the insertion of the neurostimulator. So you need one procedure code from the left-hand column with one procedure code from the right-hand column to be able to make it that procedure code combination. And then for those that are interested, if you want to see the entire list, because this was kind of just summarizing it for this slide, but if you want to see the entire list, it's 36 different procedure code combinations. Refer to table 6P.2b on the cms.gov website. Going on, this was the they added the following procedure codes to both MSDRGs 23 and 24, as well as 25 through 27, because once again, it's a replication error when we are transitioning to ICD-10. So I am still amazed that we are 10 years into since ICD-10 PCS became effective, and they're still doing some, correcting some replication errors, or omittance, if you will, after the transition of that, because it was such a huge undertaking to try to get it to the correct MSDRGs. So Cheryl, talk to us about quality for all of these changes.
Very similar. Having patients in clinically cohesive DRGs and the correct DRGs with other types of patients is going to have a huge impact on the severity of illness, the risk of mortality, the MSDRG risk adjustment as well, and again, for fair comparison. So similarly to our other set of changes, I think these are actually huge as we really think about how we measure outcomes and meaningful outcomes, because they're not as risky as that first group, but they're still more complex and riskier with, higher incidence of adverse outcomes than our, again, air quotes, simple craniotomies. And here's our next change.
Still in MDC1 for the nervous system. Here, hypertensive encephalopathy was classified to MSDRG 77 through 79. So it was one code that went to those MSDRGs, and it was based on if it was with an MCC, CC, or without a CC or MCC. Well, they've deleted those MSDRGs because the volume was lower, and also it kind of went against the grain of having one diagnosis code go to a DRG, because DRG stands for diagnosis related group. Well, a group of one is not really a group. So they decided, for the sense of DRGs, and with the low volume, they deleted these MSDRGs, and they instead moved the code, or in addition, they moved the code, the hypertensive encephalopathy code, to the MSDRG 70 through 72. As you see on this slide, that this is kind of showing the volume, the shift of everything, where in fiscal year 2025, the volume was 3,500 cases, just over 3,500 cases. That's the volume impact that it will be moving into the appropriate 70 through 72. And you can kind of see the relative weights in there as well. So the 3,500 cases are going to be added to 70 through 72 because of the deletion of 77 through 79. Cheryl.
So I think this is going to have a bigger impact than people realize, also because we have had a change in our tabular directives with hypertensive emergency, meaning hypertensive encephalopathy is an organ dysfunction, obviously related to hypertension. And we have a directive that does indicate that we would use the hypertensive emergency as principal and report hypertensive encephalopathy as a secondary. How does that impact? Well, hypertensive encephalopathy, now that it's not a principal diagnosis most of the time, or should not be in terms of good documentation and following the guidelines, it will be an Elix-Hauser condition. It is part of a very high weighted Elix-Hauser category called other neurologic disorders, where this encephalopathy and several others are located. So it will have a huge impact on our Elix-Hauser score. Again, that will be a risk adjuster for our patient safety indicators, as they do use Elix-Hauser categories to risk adjust. And then again, when we're looking at our data, typically they don't use principal diagnosis. They use secondary diagnoses and risk adjustment models. So having more of these reported as secondaries will definitely have an impact on risk adjustment. So we're going to move to our next set of changes.
Now we're moving into MDC5, the circulatory. So a new DRG was created for endovascular abdominal aorta with iliac branch procedures. So new MSDRG 213, the relative weight for this is 5.7, so it is pretty hefty weighted. 2 procedure codes are necessary to classify to this new MSDRG. One is a procedure code describing the EVAR using an abdominal aortic aneurysm endoprosthesis. And then on the next slide, the second procedure that is needed is the procedure describing the EVAR using an iliac branch endoprosthesis. So, having these 2 procedure codes, the reason for the creation of this is that these 2 procedure codes together utilize greater resources compared to the cases reporting standard EVAR using an AAA endoprosthesis. On the next slide, you'll see where things are being shifted or where are they moving the cases around from. So they're taking those procedures out of 268 and 269, and you can see the volume there. So just over 1,000 cases are being taken out of 268 and 269 and moving them into the new DRG of 213, and kind of see how it shifts around in there. And what I showed down here at the bottom of what the total number of cases were in 268 and 269, and you can kind of see that not a lot of volume are they taking out, but it is pretty significant, and that they will be being classified in its own DRG, and then we can see how things shift around in the future, and then also how this relative weight may shift in the future as well. Cheryl?
From a quality perspective, again, having new DRGs means that they will be used differently in risk adjustment for expected complications, such as the patient safety indicators. And again, having different severity of illness, different expected risk of mortality. Anytime there's a new DRG created, again, that has huge implications on how we evaluate those patients and the types of conditions that would be expected, or how frequently those complications would be expected following that type of procedure. Or maybe they have lower complications, right? Although resource consumption is higher because we now have an anchor, maybe they have fewer complications. I think time will tell, but certainly is going to have a direct impact on our quality adjustment. Next, DRG change.
Yeah, 3 new DRGs were created for percutaneous coronary atherectomy. And you can see 318, the new MSDRG 318 is for that percutaneous coronary atherectomy without an intraluminal device. And then if an intraluminal device was inserted, your stent, then that would go to 359 if you had an MCC, and then 360 if you do not have an MCC. So these were created, they will clinically requires greater resources to perform these percutaneous or percutaneous endoscopic coronary atherectomies. The next slide will show what procedures are what PCS codes would qualify for these new MSDRGs. And they're all from the 02C table and the extirpation. If an intraluminal device is added, that would qualify for 359 through 360. That's what's at the bottom, your 027 or 02H, to be able to qualify for the intraluminal device. And then on the next slide, once again, it's showing how that it would shift around from what DRGs are these new cases pulling those encounters from, or pulling those episodes from. And it would be from 250 and then 251 and 321 and 322. So we're pulling about 7,000 cases. So pulling the volume out of those DRGs and moving them into the newly created 318 and 359 and 360. So, and you can kind of see how the relative weight is playing in there as well. So Cheryl, how will this impact on quality?
Similarly, when you're putting patients with higher risk of complications together, and these atherectomies are really a good example of that, right? We know that it's not just putting a balloon in and a stent in, you're also scraping off that plaque. They have higher risk of adverse events such as coronary artery dissections, right? Or throwing embolic or thrombotic plaques out into the bloodstream and through those coronary arteries. So it certainly comes with a different expected severity of illness and risk of mortality. And again, having new DRGs to risk adjust expected rates for HRQ. So I think this is another huge change with the creation of the new DRGs and the shifting of the more complex patients into them.
Okay, our another new DRG still within NDC 5 for circulatory is the new MS-DRG 209 for complex aortic arch procedures. And notice the relative weight on this one, 11.3188. So extremely high relative weight for this procedure. But this is the reason why, because it's complex. It's a complex type of procedure, and in fact, it's a couple of different procedures that are being performed to be able to get into MS-DRG 209. So there's 4 different procedure code combinations to qualify for this. Some of them will include new technology, such as the GORTAG thoracic branch endoprosthesis or the ThoraFlex hybrid device that would qualify for this new MS-DRG. As we go on to the next slide, it kind of breaks out what each of those 4 different ways of qualifying for this new MS-DRG are. And the first one is the procedure code combination for the technology GORTAG thoracic branch endoprosthesis. So you'll see that you'll need 2 procedure codes for this: the restriction of the thoracic aorta, as well as the restriction of the another code for the restriction of the thoracic aorta. So 2 procedure codes are necessary. And then you have another technology, the ThoraFlex hybrid device, where once again you need 2 different procedure codes. And notice that this is in the new technology section still. For that would both of those procedure codes are required to qualify for it. And then the final 2 ways on the next slide are the AMDS hybrid prosthesis, as well as the other complex aortic arch procedures. So once again, more procedure code combinations that are all describing the complex aortic arch procedures. So Cheryl, talk to me about how this is impacting quality.
As a former CVICU nurse, this is huge, meaning of all the patients we saw, other than the aortic root operations on the aortic root directly, these are some of the most complex to care for patients. They had the worst incidence of complications, not due to surgical technique, just it's very high risk surgery. So them being in their own sort of DRG where they belong, to be clinically honest with you, not just clinically, but reimbursement wise, but for them being in their own DRG with their own expected mortality, complications, et cetera, is absolutely huge. And I think, again, will be utilized differently in those models for risk adjustment. So for me, this is a long-awaited welcome change as well. And here's our next change.
Now we're moving on to the spinal fusions, and now we're in MDC 8 for the ortho MS-DRGs. This slide is kind of summarizing the MS-DRG logic to be able to qualify for MS-DRGs 456 through 458. And that's those MS-DRGs for spinal fusion, except cervical, with spinal curvature, malignancy, infection, or extensive fusions. Now, so there's several different ways of being able to qualify for here that you'll need, and each one is specifically defined as to what it is. So this one, once again, is just showing the 4 different logic lists that are available for these MS-DRGs. So with that in mind, going on to the next slide, you'll see that to one of those logic lists, they added 47 diagnosis codes to the spinal curvature, malignancy, and infection logic list this MS-DRGs 456 through 458. And so those are going to include, the salmonella osteomyelitis, and going on down the list, you'll see other osteomyelitis that are included in here. So it's just, they were clinically appropriate to add to the existing diagnosis codes list for describing spinal infections. So they added these 47 diagnosis codes here. And then on the next slide to once again, to a different logic list, the spinal curvature malignancy infection, well, same logic list, but they deleted 8 diagnosis codes from their uh, describing collapsed vertebra, age-related osteoporosis, because this didn't really qualify for a spinal curvature or a malignancy or an infection. So they deleted these 8 diagnosis code from that list. So Cheryl, I'll turn it back over to you to talk about how this can impact on quality.
Again, clinically classifying the right patients and the right DRGs, especially those that have moved into the appropriate DRGs, I think is very, very important because they belonged in there with like patients in terms of more complex patients with more complex procedural difficulty and higher risks of complications. So it will have an impact on the MSDRG risk adjustment and in the risk-adjusted models when looking at resource and consumption. And conversely, those patients who did not belong in those DRGs, because a collapsed vertebrae is not the same thing as a spinal curvature, moving them out appropriately will again reset the population and really look at fair comparisons in terms of outcomes and again risk of mortality, etc. And here is our next topic.
Now every year CMS always looks at if something impacts or does not impact, if a procedure code does or does not impact MSDRG, should it or should it not? So should they add it to the operating room list that would impact on the DRG, or should they remove it? So this year, for the endoscopic drainage of the ureter, so ureteral drainage with a drainage device, they decided to add it to the operating room list. So it will impact on the MSDRG assignment. So these 3 procedure codes, and they're broken out if it's right or left ureter or bilateral ureters, that it will now impact on the MSDRG assignment if it is performed. And you'll see the list of DRGs that it could go to depending on where the principal diagnosis is located. So the reason for this is that these procedures are typically performed in the operating room under anesthesia. So they're surgical in nature. So they are now adding them to the OR procedures that will now impact on your DRG assignment. Of note, I think these always did impact on the APR DRG assignment, moving them to the surgical side. So now the MSDRG is making that consistent with that. Cheryl?
So again, when you have patients that are really surgical patients, these are performed in an operating room, right? These are surgical procedures that have high risk of complications, including infections and dissections and things like that. Moving these patients into a surgical DRG either will increase your denominator of surgical patients instead of medical patients. So we would possibly have a small increase in our PSI as an example, but we'll also, again, have them classified appropriately for risk adjustment in terms of severity, mortality, all those other things. So I think this is, I think it's a good movement and an appropriate reflection of not just the resources involved, but the fact that these are truly a surgical patient and should be considered part of the surgical population. So we're going to transition now into CCMCC updates and how those impact quality.
First of all, I will say that no existing diagnosis code was added or deleted from the CC or MCC list this year. So the only updates to the current CCMCC list are any of those new diagnosis codes that were expanded, and they basically follow the predecessor code. So if the predecessor code was on the CC list, then so were the new codes. And so nothing was really deleted or added to the CC list. But also every year, CMS looks at those conditions that could be excluded as a CC or MCC, depending on what the principal diagnosis is. And that's what's showing on this slide. There was what appears could be a significant change, but when I explain it to you, it's not really that significant of a change. And here's why. They were looking at the CC of the chronic kidney disease stage 5, N18.5, and also the MCC of end-stage renal disease, which is N18.6. So that's the CC and MCC that's going to be impacted. When that code is assigned with one of these principal diagnoses that's listed, that's in the second column, then it's going to be excluded as a CC or MCC. And you're like, oh my goodness, they're excluding end-stage renal disease as an MCC in some of these instances, or they're excluding the CKD stage 5 in one of these instances. But look at what the principal diagnosis included on here are. It's a combination code, the hypertensive heart or hypertensive heart and kidney disease procedure or diagnosis code, but it's with stage 1 through stage 4 of CKD. So in other words, I should never, I'll say it again, I should never assign a CKD stage 5 with the hypertensive CKD stage 1 through stage 4, or the hypertensive heart and chronic kidney disease stage 1 through stage 4, because that wouldn't make sense. And my end-stage renal disease, I shouldn't be assigning it with the stage 1 through stage 4 combination code for the hypertensive heart and chronic kidney disease. So although yes, they are excluding a CKD stage 5 and the end-stage renal disease from certain principal diagnoses, it's those principal diagnoses that you shouldn't be assigning it with anyway. So, and that's the purpose for the exclusion list, is to kind of not allowing a mistake to impact on your MSDRG assignment. So it's not going to make it become a CC or MCC. So it will be excluded with one of those principal diagnoses that are listed here. On the next slide, another change that they made to the CC exclusion list is that there are certain secondary diagnoses that, when present in a patient who has expired, will not count as a CC or MCC for that case. And it's been the cardiac arrest, your ventricular fibrillation, respiratory arrest, cardiogenic shock. So this has been around for a long time. They've this year modified a couple of things. They've removed the hypovolemic shock from the list. So in other words, if a patient does have hypovolemic shock and they expire, it now will be included as a CC or MCC. And I think it is an MCC if I'm correct. And then, yeah, will be assigned as an MCC. And then they've added the traumatic shock, the T79.4XXA to the list. So now if the traumatic shock is present in a patient who has expired, it will no longer be an MCC for this encounter. So this is just, once again, an exclusion list. And if the patient expires, it will be excluded as a CC, but so those are the changes to this list at this point. So Cheryl, talk to me about quality on these two CC exclusion list changes.
As Audrey said, the first one is a nothing burger, right? Meaning sometimes we want to show you, although it seems huge, it also does not impact quality per se, right? The second one, however, with the removal of the traumatic shock, that is significant, and because not being able to capture that in a patient who dies it is certainly going to be, again, a negative impact, if you will, on risk adjustment in any of the models, whether it be AHRQ or somebody else's models. Not being able to capture a code means it can't be utilized in risk adjustment. Again, feels a little sad to me, if that makes sense, because Honestly speaking, it's, it's been on the list a long time. And as Audrey will tell you, there's not been a change to this list in years. So why now and why this code? I just don't know. Like I said, I think it does have this bigger impact probably on quality than it did actually on reimbursement. So not all changes were good changes on quality. So we're going to transition now to the Solventum APR DRG changes that are DRG updates that might impact quality.
Yes. And you'll see here just kind of comparing version 42, which was prior to October 1st, versus 43. Version 43 is effective October 1st. Kind of where things broke out. There were 3 new base APR DRGs that were created for version 43, 7 that were deleted, and 7 that were revised. And for the 3 APR DRGs that were created, you'll see one on the next slide. You'll see one for in MDC1, which was 60, which is head trauma with coma, less than 1 hour. In MDC 23, 864 was created for hospice and palliative care. And in MDC 24, APR DRG 891 was created for HIV with major HIV related condition or multiple HIV significant related conditions. So those are the 3 new ones. Cheryl, talk to me about how this is impacting quality.
Even more so in the APR DRG world, those changes in new APR DRGs directly impact obviously risk adjustment when it comes to risk of mortality, as an example, an expected risk of mortality. So combining, merging, shifting diagnoses into these DRGs are making similar changes to what CMS did, which does happen an awful a lot, and not as a negative, but it's saying we do try and align with CMS in terms of the way that they classify patients for, again, resource consumption, because remember, APR DRGs are also used for payment by, over 40 states. So, there is definitely a shift and an impact again on reimbursement. Also, remember that HRQ is an all-payer methodology, right? Meaning it's not just MSDRG patients. So again, the shift in the DRG assignment will also impact that as well. So again, nice changes, but as the Wicked musical says, no good deed goes unpunished. Well, we don't know. Like, I'm not all calling these all negative, but every action there is an opposite reaction or a different reaction. So we'll see that in the APR DRG world as well. Audrey, back to you.
So these are the deleted APR DRGs. The first 2 are actually because the new one was created. So all of these will be shifting to the new APR DRG. Then in MDC 6, gastric fundoplication was deleted. MDC 13, there were 2 that were deleted. You'll see later that they were actually revised. The title was revised, so you'll see where they were shifting around to the existing APR DRGs. And then in 24, the new HIV one that was created, they're deleting these 2. They basically combined APR DRGs 892 and 893 into the newly created one that we showed on the previous slide. Cheryl, how is this impacting?
Again, very similarly, those shift or creation of those patients, shifting patients into either newly created or existing APR DRGs is going to have a direct impact, especially on risk adjusted and expected rates of risk of mortality, even more so, because we know that APR DRG methodology. And we will go on to our next change.
are showing the shifting or the revised APR DRG titles, and kind of what you see in the third column over is the words that may have been deleted from the title, and then what was added. So it does look like subtle changes, if you will, that they're maybe revising terminology in here, but then also sometimes they're just kind of updating the terminology to make it more current. So Cheryl, talk with us about this one.
Again, probably not a big impact, like I said, except for the fact that where they'd made some revisions, it's also because they were including procedures from deleted APR-DRGs into these. So in those instances where they did move patients into those DRGs, that will impact risk adjustment and expected risk impact, because you're now lumping in, and I'm not saying it's wrong, but you're putting similar patients in who may or may not have the exact same risk of mortality. And obviously, all seriousness aside, our clinical and economic research team who maintains the APR-DRG methodology really does look at the risk adjustment, not just the resource consumption, but making sure that they're clinically cohesive for not just payment, but for also fair risk adjustment. So I'm going to compliment them and say they didn't do this for no reason. There was a well thought out process. It definitely will have some impact on risk adjustment. And with that, we have concluded our portion of our annual education, if you will, on how all of our changes impact quality. And we appreciate everybody's participation every year. We seem to always have a big interest in this topic, and just know that we appreciate the interest. And to be honest, it's one of our favorite decks to put together. It does take a fair amount of time, Audrey and I will tell you, to think through and go through all the decks and debate, discuss the significance of the different changes, but we value everyone's interest. And with that, we will end our recording.